really, we discovered last year, an overwhelming experience in the business of Ehlers-Danlos syndrome and a systematic approach to the clinical diagnosis.
Thank you all for coming on a Saturday to learn about Ehlers-Danlos syndrome and to discuss the very many issues connected with this condition that are still really, as you will hear, there are many, many things that we need to understand better than we do now. But what I'm charged with today is to give a clinical overview of how we're thinking about Ehlers-Danlos syndrome in 2014. There we go. Is that working? Okay. So the cardinal clinical features of Ehlers-Danlos syndrome include joint hypermobility, joint subluxations and dislocations, and joint pain. And the skin is hyperextensible, soft, with atrophic scarring and striae. The major types, and you'll hear more about this from Dr. Mendoza in just a few minutes, but there are now about 9 types of Ehlers-Danlos syndrome. Where's Roberto? I don't want to get that wrong. How many types? Yes, okay, so they've stopped numbering them, and we've got names that have now been added because there are a number of very rare types that have been identified. But the major types are the classical, hypermobile, and vascular types. And the classical type is marked by joint hypermobility, extremely stretchy skin, profound skin fragility, and profound atrophic scarring. And I'll show you some pictures of these in just a minute. The hypermobile type has joint hypermobility and mildly stretchy skin with atrophic scarring and striae. And the vascular type also has joint hypermobility, and particularly this can be in the small joints of the hand. But the people with vascular Ehlers-Danlos syndrome also develop arterial aneurysms, and these are typically in the medium-sized arteries of the abdominal cavity, so like the splenic artery and the gastric artery, the hepatic artery. May also involve the carotid arteries or the femoral arteries. And they have fragility of the hollow organs, so that the vascular type of Ehlers-Danlos syndrome predisposes people to rupture of the bowel, the uterus, and the bladder. And the vascular type is life-limiting because of these complications. Now, when you look at this slide, this is what most doctors who are familiar with Ehlers-Danlos syndrome know about Ehlers-Danlos syndrome. And unfortunately, many of the geneticists who trained a while ago or who haven't had a lot of experience with Ehlers-Danlos syndrome, this is what they know. And it really does not give a complete picture of the experience of Ehlers-Danlos syndrome for many, many patients. So just to review the Beighton Score, which is the measure by which we look at hypermobility, patients, we look at there are 9 different assessments that we do in looking at the Beighton Score. First, we look at the joint, the elbow. Trying to find, here we go. Okay, so we've got the elbow and we measure, and I recommend to physicians who are doing this assessment to use an instrument called a goniometer, which actually measures the degree of angularity at the elbow. And if it's more than 10 degrees beyond 180, we call this hypermobile. And clearly this young lady has a hypermobile elbow. Then we look at the hypermobility at the 5th finger metacarpal phalangeal joint, this joint right here. And if this goes beyond 90 degrees, which this one clearly does, we call that positive. And of course, we have 2 elbows and 2 fifth fingers, so you get 2 points if this is elevated on the right and the left, and 2 points for the 2 pinky fingers. We ask people if they can touch their thumb to their wrist, and we see whether there is more than 190 degrees of hyperextension at the knee. And then the 9th point is whether or not people can put their palms on the floor without bending their knees. So you get 1 point each for each arm, for each pinky, for each thumb, and each knee, and then 1 point for being able to put your palms on the floor. And the total Beighton score is out of a possible 9 points. Now, there are differences among articles in the literature. Some authors have suggested that a score of 4 or more is sufficient to identify a hypermobility, and others have said it must be 5 or more. The Beighton score clearly changes with age, and this is one of the areas for which a greater research is needed. Now, the skin features include the stretchy skin and atrophic scarring, and then stretch marks. And one of the unusual things about the stretch marks in patients with Ehlers-Danlos syndrome is that they can develop before people ever gain weight. It's not associated with weight gain necessarily. And also, typically, there may be stretch marks across the lower back that are horizontal to the floor. This is the kind of stretchiness we see in the classical type of Ehlers-Danlos syndrome. This little canine friend here is an excellent model for Ehlers-Danlos syndrome. Now, recently, Dr. Castori, who writes from Italy, has published a very, very excellent review about the next generation of understanding for Ehlers-Danlos syndrome. And he writes about Ehlers-Danlos syndrome as a multi-system disorder, and this was published in Dermatology in 2012. And what Dr. Castori has recognized here is we have joint hypermobility syndrome in the middle. And I should say that among rheumatologists, there is an entity that they call joint hypermobility syndrome. And over the last couple of years, the rheumatologists and the geneticists have come together, and we've come to understand that what the rheumatologists have been calling joint hypermobility syndrome and what geneticists have been calling the hypermobile form of Ehlers-Danlos syndrome are really one and the same thing. So, and I believe that any genetic disorder characterized by joint hypermobility puts people at risk for these other complications. In particular, in Ehlers-Danlos syndrome, we see chronic pain, chronic fatigue syndrome, functional gastrointestinal disorders, chronic headache disorders, pelvic dysfunction, endocrine gland dysfunction, cardiovascular issues, including dysautonomia, and immune dysregulation. And I've included a few things down here which Dr. Castori did not include, but which clearly seem to be part of the experience of Ehlers-Danlos syndrome as we understand it in 2014. And these include mast cell dysfunction, bleeding and clotting disorders, and neurologic complications. I'm going to give a brief overview of some of these issues now, but you will be hearing much more about each of them as the day goes on today. So pain in Ehlers-Danlos syndrome may be muscular, it may be myofascial, neuropathic, it may include headache, abdominal pain, pelvic pain, and complex regional pain syndrome. In the clinic at Greater Baltimore Medical Center, which is now the Ehlers-Danlos National Foundation Center for Clinical Care and Research, We use the brief pain inventory to document each patient's experience with pain, and this is the form that they fill out every time they come to the clinic. And they rate their pain on a scale from 0 to 10, with 10 being the most severe pain a person can imagine. I'm sure many of you have had experience with this questionnaire. So among our patients with hypermobile Ehlers-Danlos syndrome and with classical Ehlers-Danlos syndrome, over the past 3 years, the average pain score on arrival in our clinic is a 5 for both classical and hypermobile. And the worst pain score on average is an 8 for people with hypermobile Ehlers-Danlos syndrome and a 7 for the classical Ehlers-Danlos syndrome. And we look to see over age whether or not this changed, and really there is not a significant change over time for the ages of our patients as we assessed it. You will hear from Dr. Rowe about chronic fatigue syndrome. This patients experience profound, disabling exhaustion. And many of my patients have told me that the fatigue can actually be more disabling than the pain. Sleep disturbance is a major contributor to this, but other possible contributors include adrenal dysfunction, hypothyroidism, and mitochondrial dysfunction. And again, Dr. Rowe will address this in much greater length, but the end result is that often people feel that their joints go out more than they do. In assessing the sleep studies, it's very important to look at what we call the sleep architecture. Often we send off for a sleep study, and the sleep doctors are pretty typically tuned in to looking for sleep apnea, but sleep apnea is usually not the issue. The issue is that people are not spending enough time in deep and restful sleep, and as a result, they're feeling the effects of sleep deprivation, which can mimic many of the symptoms that we're talking about as complications of Ehlers-Danlos syndrome. The gastrointestinal complications in Ehlers-Danlos syndrome are many. They run really the length of the GI tract, including dysphagia, esophageal dysmotility, esophageal spasm, GE reflux, hiatal hernia, problems with motility, including gastroparesis and large bowel dysmotility, irritable bowel syndrome, and rectal prolapse. Headache is a very, very common complication in Ehlers-Danlos syndrome. Patients have muscular headaches. They may have myofascial headaches. They may have neurogenic headaches or migraine. TMJ dysfunction can cause very significant headaches. And patients may also develop CSF leaks resulting in decreased intracranial pressure, or they may have Chiari malformation resulting in increased intracranial pressure. And they may have disruption of venous drainage with an entity called chronic cerebrosinus venous insufficiency. You'll hear a lot more from Dr. Henderson about the neurosurgical issues, but increased intracranial pressure includes symptoms of a pressure headache, which is sensitive to changes in the barometric pressure. Some of these patients may present with evidence of a CSF leak, and some women report increased symptoms around the time of their menses because of the increased volume that they carry during that time, blood volume. The increased intracranial pressure is documented by increased pressure on lumbar puncture or intracranial pressure monitoring. And there are multiple potential causes to increased intracranial pressure, including Chiari malformation, disruption of CSF or venous blood flow, and it may be responsive. In many patients, I've experienced that they are responsive to Diamox therapy, which decreases the volume of cerebrospinal fluid. But it's important to remember that Diamox does decrease bicarbonate levels and cause metabolic acidosis. So it's very important to monitor the bicarbonate levels closely. Pelvic dysfunction is another important phenomenon in EDS. Patients experience pelvic pain, uterine prolapse, bladder prolapse, dysfunctional uterine bleeding, and sexual dysfunction. And when we looked again at our experience over the last 3 years, and compared the classical and hypermobile types, you'll see that there's really not that much difference between the two. 30 and 38% experience urinary urgency, 21 and 26% urinary incontinence, 40 and 38% reported urinary frequencies, and recurrent UTI was found in 9 and 10% of the classical and hypermobile patients, respectively. Exocrine gland dysfunction, this is another area that really needs a lot more investigation. We see many, many patients who come in with evidence of pituitary, thyroid, pancreatic, adrenal, ovarian, and testicular dysfunction. And one of the important contributors to that is the fact that the pituitary sits in a lake of cerebrospinal fluid in the brain and is very susceptible to increases in intracranial pressure. And the pituitary gland is really the master gland that controls the function of many of these other endocrine functions. And so when the pituitary isn't happy, the rest of the endocrine glands are not happy. Cardiovascular manifestations include mitral valve prolapse, aortic root dilatation, venous insufficiency, tachycardia, orthostatic intolerance with postural orthostatic tachycardia syndrome or neurally mediated hypotension, and also chest pain, which is usually not related to typical, what we think of as angina or cardiovascular disease, but is more typically a so-called atypical chest pain. And this may be related to mitral valve prolapse for one possible cause. May also be related, patients with POTS also report chest pain associated with their postural orthostatic tachycardia. And here, among our patients over the last 3 years, palpitations were seen in 56 and 52%, syncope in 19 and 26%. 2/3 of the patients reported dizziness, and 40 and 37% reported chest pain. Immune dysfunction includes, there's a subpopulation of patients with common variable immunodeficiency, and I have patients with a wide range of autoimmune disorders, including systemic lupus erythematosus, rheumatoid arthritis, psoriasis, Behçet's disease, and mixed connective tissue disorder. And really the most recent arrival on our landscape of Ehlers-Danlos syndrome is the phenomenon of mast cell activation disorder. So there is a subset of Ehlers-Danlos syndrome patients who develop symptoms of mast cell disease, which includes flushing, hives, even anaphylaxis. And many of these people respond to therapy for mast cell disorder. The mast cells release histamine, and so histamine blockers, including H1 and H2 blockers and chromalin sodium, which is a mast cell stabilizer, can be very, very effective for these patients. And the mast cell disease may reflect increased stress levels and/or autonomic dysfunction. We really don't have a very good handle on exactly what sets it off. Hematologic complications include easy bruising and bleeding complications, so we can, so many patients have been diagnosed with von Willebrand syndrome, but they do not have the typical laboratory findings of von Willebrand syndrome. In addition to the bleeding complications, we can see clotting complications, so patients may have an increased risk of deep venous thrombosis. And malabsorption issues in the GI tract may lead to iron deficiency and iron deficiency anemia. In terms of neurologic complications, again, you'll hear much more about this from Dr. Henderson. We see craniocervical instability, Chiari malformation, the development of syrinx, which is a the formation of a lake of cerebrospinal fluid in the interior of the cervical or thoracic spine. Cervical instability, which may be at C1-2 or lower. People with Ehlers-Danlos syndrome have a remarkable predisposition to degenerative disc disease. And when we look at the MRIs, even of people in their teens, we see that the discs have shown evidence of degenerative disc disease. Occult tethered cord is another phenomenon, and the autonomic nervous system dysfunction, which has manifold consequences. Because the autonomic nervous system affects virtually every organ system in the body, we can see manifestations in virtually every aspect of human functioning when the autonomic nervous system is not working well. And the common features that we see with autonomic dysfunction include postural orthostatic tachycardia syndrome, neurally mediated hypotension, sleep disturbances, exocrine dysfunction, the gastrointestinal dysmotility, as I mentioned, and many patients report that they have temperature instability where they're either always the coldest person in the room or always the hottest person in the room, or they're constantly taking on their jacket and taking it off because they just can't get to a comfortable temperature. There's the interesting issue of drug metabolism in this population. Many patients with Ehlers-Danlos syndrome do not metabolize drugs as expected. And many patients have also reported that they are slow to respond to the cane derivatives in the dental office. For example, they'll need multiple injections, and then they get multiple injections, but once they are successfully anesthetized, it wears off very slowly. And the metabolism of many other drugs seem to be either prolonged or accelerated. So we have been using the Genelex test, the UScript test, to look at the CYP genes that are involved in drug metabolism and find this to be a very helpful test to help guide pharmacologic management. Ehlers-Danlos syndrome, and I need not tell this to this audience, I'm sure, but it can be disabling. And we use the Karnofsky Performance Status Scale to assess how well people are functioning in their daily lives. We ask patients to circle the number on this scale that gives us the best representation of how they are functioning. So 100 is I feel normal, I have no complaints and no evidence of disease, and 10 is I have fatal processes that are rapidly progressing, I am near death, and then the rest are kind of in between. And again, looking at our most recent study of our patients, on average, the mean Karnofsky score for the hypermobile patients was 71, and the classical was 67. And again, we did not see really a significant change over time. And just for a guideline here, 70, the sentence reads, I am able to care for myself, but unable to carry on normal activities. So I'd like to offer my thanks to my colleagues, Ms. Christy Hackinson, Dr. Henderson, Dr. Posinki, and Dr. Gerwin. And Dr. Mankey, Baig, and Kahn collected the data from our clinic, and certainly my thanks to all our patients and their families who've allowed me to share this journey with them. And I'm happy to take questions. Yes.
I do have a question, which is, I know that the waiting list for folks to see you is quite long, and my presumption is that the folks that you see may have more severe symptoms than the whole universe of patients. And I wonder if you want to comment on that, because as someone who may have a family member with this illness, it's kind of scary to see every possible body system looking so horrible.
So this is absolutely true. I think the people who come to see me, I do see a more population that is a little bit more skewed towards people who are struggling, because patients who are doing well don't require attention. And so the way that we really need to evaluate that, and I think it's a research effort that needs to be conducted, is to look at the family members of those patients who come to see a clinic like mine or Dr. Mendoza's, and see, you know, for those people who have not come in, what is the range of experience. But you're absolutely right, and there are many people who have joint hypermobility who do not experience all of these symptoms. And one of the most important things for us to understand is what distinguishes those who are doing well and functioning in the world from those who experience these, you know, disabling consequences.
Thank you.
Yeah, so I work at the Hospital for Sick Children, and I was very interested in how did you put together your national Foundation Center for Ehlers-Danlos in Baltimore, and what constitutes that center? Is it a center in which you see both children and adults, and they come together and a whole bunch of services are present for those appointments, or how does that center function?
So we are a center in evolution right now, I would say. We have a pediatric geneticist, my colleague Dr. Tony Klein, who works with me. When I proposed the center to the Ehlers-Danlos National Foundation, I said that we have in the Baltimore, Washington area a virtual center. So we don't have at GBMC, at the Harvey Institute where I work at, all of the specialists that people need, but we have within the Baltimore, Washington area all the people that we refer to. And so when people send us their information, we review it and we ascertain what specialties they are likely to need. And then often people are flying in from a long distance, and so we try to make sure that they have appointments with all of those specialists within a 2 or 3 day period. And so that by the time they get home, at least they will have consulted with the appropriate people and be set, you know, have some recommendations for moving forward.
Okay, thanks very much.